That's great. It's gone quiet without me having to ask, which is which is perfect. If everyone sits down. Hi. Well, welcome everybody to this parallel session. We're going to be hearing about 3 pieces of School for Social Care Research, NIHR School for Social Care Research. I've just seen Louise take her seat. NIHR School for Social Care Research on older people. And yeah, so welcome everybody, and it's great to have been asked to chair this. I'm John Wilkinson. I work in the Science Research and Evidence Directorate on sort of health systems and social care research. So yeah, it's great to have been invited to do this. And yeah, we've got 3 presentations. I mean, it feels like a trajectory. We're going to start with delayed transfers, move into home care, and then look at volunteers in care settings. But if I introduce Karen Jones from University of Kent, and yes, if you, I'll step aside.
So thank you for attending this session. So I'm Karen Jones. I'm the Director of the Personal Social Services Research Unit at the University of Kent. I'm also the Principal Investigator for a NIHR SSCR funded project that has recently explored the influence of social care on delayed transfers of care among older people. So, as background, as we know, delayed transfers of care is a high priority issue for the government, in particular to find in ways to reduce or prevent delayed transfers of care. The National Audit Office estimated that delayed transfers of care among older people cost the NHS up to £820 million every year. Among those delayed in hospital, many will require social care support from their local authorities following discharge. So therefore, there's a significant impact on the health and care sector, but also there's a significant personal impact of patients who stay in hospital when they're medically fit to be discharged. So this was a two-year project that explored 2 questions: why delays are happening and how might they be reduced or prevented. There are a few studies that have explored the relationship between local detox rates and social care expenditure and supply. So the current study aims to bridge the gap in evidence. The study developed case studies that highlighted in detail local discharge approaches, and we've used the case studies to inform and explore the quantitative findings. We also explored the local links between detox rates and integration initiatives such as the Vanguards. So today I'm going to present on our initial findings. We are due to submit the final report to SSCR at the end of April. So these findings are very much new, and they are initial findings as we work towards that final report. So can social care influence detox? So Stephen Allen from PSSIU completed the analysis. He used national detox datasets that are submitted to NHS England to understand the influence of social care and overall detox. So patient days between 2011 and 2016 Within the models, a number of factors were controlled for example, local authority social care expenditure, population data, house prices, and benefit updates. In terms of the measure of care home bed supply, Stephen used the count bed, care home beds in each local authority, and he also used the CQC data concerning home care supply. So what did we find? That an increase in care home beds reduce local detox rates. We also found an increase in home care supply reduces detox rates. These are the local detox rates. However, there needs to be some caution that detox could be driving increased social care supply. So what are the other influences on detox? Initially, we wanted to explore the current local discharge arrangements. So my colleague, Tari, actually ran the analysis, and would be happy to, Stephen and I would be very happy to answer the questions around their analysis after this presentation. So we invited local discharge teams to complete an online survey to explore their local discharge arrangements. A range of discharge policies were identified across 31 participating areas in this study. The approaches varied greatly, and only two things really stood out: whether the discharge team were co-located, and whether care homes, care providers, whether they were involved in the discharge process. The findings highlight that we cannot conclude if discharge approaches alleviated detox using the national detox datasets. We also, one of the aims of the project was to look at the influence of integration, the various integration initiatives, and whether there's an impact on detox. So as we know in the room, that integration between health and social care continues to be a key policy aim. I was involved in the system-level evaluation of the Better Care Fund alongside colleagues from LSE and the University of Oxford. And we found it appeared that the Better Care Fund reduced detox, although the evaluation team were unable to conclude that BCF affected emergency admissions. So we suggested that the effects of BCF on detox are indicative of improved integrated working between health and social care. You can find our final reports on PSSRU's website for further information around the system-level evaluation. So we found that the Better Care Fund potentially has an impact on detox. So we looked at, so what about the vanguards? So this is a current programme, and they're looking at testing new ways to deliver health and care services. There are 5 vanguard types that are focused on primary and acute care systems, care homes, community providers, urgent and emergency care, and acute care collaborators. For this specific project, we've focused on the urgent and emergency care vanguard because some of the areas participating in the current SSCR project were also are also involved in the vanguard in terms of urgent and emergency care. So in terms of what this vanguard's looking at, it's looking at to transform urgent and emergency care, which includes implementing a new model of integrated urgent care through NHS 111, strengthening data sharing and IT infrastructure, implementing the channel shift modelling tool to plan and facilitate service design, which includes 16 interventions such as a rapid response service to support discharge and prevent admissions, discharge to assess, which involves providing 24/7 nurse-led care for patients who need to recover from an acute illness before assessment, and discharge planning. So this is around planning for discharge early on in the process. So we explored the impact of the vanguard. So we had 9 of our participating DTOC areas were also involved in the vanguard, and the findings seem to suggest that there's a link between the vanguards and this specific vanguard and reduction in DTOC days since implementation in 2015. In another project, we are going to be exploring the impact of the other vanguards on delayed transfers of care. So we're just specifically looking at this particular vanguard because we've got participating areas that are participating in our DTOC project. But we did find a link associated with our 9 participating areas, but we also looked at all the authorities involved in this specific vanguard. So there's 29 authorities that are involved in the urgent and emergency care vanguards. And we found a link to suggest that this vanguard, this vanguard is actually having an impact on DTOC. So once Tari actually found this result, we were thinking, so what are the possible explanations for this? So it could be one of the interventions having an impact on local DTOC rates, but which one? Those 16 interventions. So my colleagues at the University of York, Yvonne Burks and Kate Baxter, who led on developing the case studies, looked at whether the case studies could actually inform why we've actually found this result. And one explanation is around the importance of planning for discharge from a mission. However, there could be other explanations why we've actually found this finding, because as we know, there are many initiatives around integration that are currently being implemented, and so there could be other explanations. It could be, for example, information flow. So other explanation, we need to actually explore the other reasons why we've actually found this result. Which it could actually mean another project, because what the current project's actually found very interesting results around the social care influence, but also around Vanguard. So potentially there's a future project, DTOC project. We, in terms so I've said previously, the final report is due to be submitted at the end of this month. We did run a workshop earlier in the month to collect a number of thoughts of how we should be disseminating the findings. And so we came away from this the workshop with a number of ideas of how to disseminate the findings, and also who should we be speaking to. Because one of the aims of the project is not just to deliver a final report, but just to have to make an impact on policy, because delayed transfers of care is of high importance to the government. It's also important to people being prevented from leaving hospital. So we really want to actually make a difference. So we organised a workshop to gather people's views, particularly on how we should actually start disseminating the findings once we've actually submitted the final reports. I would like to acknowledge the whole of the research team across the University of Kent and the University of York, who have led on some of the specific data analysis in terms of whether it's quantitative or qualitative. So I'm just presenting on their findings. So the disclaimer that the views expressed are those of the research team that are not necessarily those of NIHR, SSCR, and Department of Health and Social Care. So I think the aim is to have questions after each of our presentations, so we have enough time for all the presentations. But my contact details are actually in your book, so I'd be happy to answer questions following today.
That's brilliant. Thanks. I was just going to say you're running 3 minutes ahead, so if
wow.
there's any quick clarifications now, otherwise...
3 minutes.
Oh. Who's first? Michael?
Yes, hello. My name's Larry Gardner. A clarification and also perhaps the indication for a future project that you alluded to. So £860 million worth of failure demand in the system because of delayed transfers of care. I think a future project might look at how much of that failure demand is shunted from the discharge ward right back round to A&E when discharges are not successful and sustained, with individuals being sustained well at home. And I'm wondering if you had any data or any data emerged from your studies. And the other clarification is, did you find any link between the data that you collected and analysed and the data from the ONS on unpredicted deaths, preventable deaths, and excess deaths, which seems to have turned a curve since 2010?
All very good points. I like that future project. We haven't explored the link with the ONS data, but again, there's something that we can explore in another study. But all really good points, and I really like your future project. So thank you. I will talk to you at lunchtime.
Great. Well, something. Any one other quick one, or shall we just go? Shall we go straight on to? Can I introduce and welcome Karen Davis and Sue Davis? Are you going to do this one at a time, half and half? You know what you're doing. From the University of Manchester. Thanks very much.
I'm Sue Davis, and I'm presenting today with Karen Davis. We're from PSSIU at the University of Manchester, and we've been looking at the processes and partnerships in place in the commissioning of home care for older adults and the associated challenges. Care at home generally involves help with ADLs, IDLs through multiple visits each week to present admission or delay admission into residential or nursing care. The majority of home care is funded by local authorities for those that are eligible, and about 30% of those receiving home care are self-funders. Local authority expenditure on home care for older adults was £1.8 billion in 2013-14. Local authorities, once providers of social care, are now enabling agencies, focusing more on the commissioning of services rather than their provision. Commissioners now must ensure that there's an adequate supply of services available to meet the needs of older people living at home. Most care is provided by for-profit businesses in response to policy championing market approaches, resulting in care providers and local authorities operating in a contractual relationship to ensure that home care is provided. From the literature review, we identified few studies specific to commissioning home care for older people in England. Only 22 papers were identified. The literature did indicate that market models for home care are complex and that managing them is at an early stage of development, and also that the relationship between the commissioners and providers influences service provision. The aim of the study was to investigate the interface between commissioners and care providers of home care, with the objectives of describing current commissioning arrangements, exploring the partnerships between commissioners and providers, and also to consider the changes in commissioning arrangements. Data collection involved 3 stages. Firstly, a national survey of local authorities was undertaken. 109 responses were received to give us a response rate of 72%. We are currently in the process of comparing the 2017 data with 2007 data collected in a previous study to identify areas where commissioning practice may have changed. Following the survey, 20 interviews with care providers were undertaken and 10 interviews with commissioners were also undertaken. And I'm going to talk you through the findings from the national survey, and then Karen will talk about the findings from both sets of interviews. So first of all, some background on who provides care. First of all, the provider market is complex. Most local authorities have a combination of both large and small providers, and the largest section of the pie chart there, which I'm not sure if you can read it, is the proportion of authorities that had 2 or more large providers with multiple small, and that's 72%. In terms of types of providers, most local authorities, again, have a mix of providers that operate in multiple local authorities and those that operate specifically in one local authority. Other notable providers include community interest companies, the third sector, and housing associations, but 30% of local authorities, almost 30%, sorry, provide some home care within house. In terms of supply, 40% of the commissioners we spoke to were unhappy with the number of providers that they had at the moment. Either they had too many or too few, and half of them had experienced provider failure in the last 12 months. The following slides are the findings regarding the process of commissioning that are in place in local authorities, and they're reported under the 4 headings of contact, so who's in contact with commissioners, control, what's the contractual obligations of providers, collaboration, who are the stakeholders that have some input into the commissioning process, and checks, which looks at the monitoring of home care. So this first slide looks at the partners or individuals that commissioners have contact with, and as you can see, there's quite a few. The The pie charts represent the proportion of commissioners that have weekly contact with each of these partners or individuals. And by weekly contact, we mean emails, telephone, or face-to-face contact. Of the groups that operate outside of the local authority, providers has the largest proportion of commissioners contacting them on a weekly basis at 62%. Communication with providers was also high in local authorities, with regular provider forums that operated on at least a three times a year basis. Next, if we look at control in terms of what's specified within a contract, 67% of authorities had contract lengths of 4 years or more. In most local authorities, tendering arrangements required providers to state a range of conditions, such as monitoring, outcomes for individuals, flexibility in provision, and the provision of specific activities. Staff conditions and training were less specified, such as the payment of travel time, sick pay, mileage, and specific training, for example, dementia training. Most commissioners said that they collaborate with partners across the following things. So it's the analysis of need, determining priorities of service development, identifying service outcomes, developing service specification, developing monitoring mechanisms, contingency planning and service planning. So it does seem to be a two-way process. Next, these are the same for the communication, collaboration with CCGs, and then for service users. And in all instances, collaboration with providers is higher. Next, we move on to monitoring data. Data from home care providers and service users was favoured. There was little variation between local authorities in terms of what monitoring data was used, how it was used, how frequently it was used. The final question of the survey asked commissioners to consider the planned changes in the future that they had for their commissioning process. And by far the greatest one was the commissioning for outcomes. That seemed to be something that many commissioners had on their to-do list, and many made the comment that it had been on their to-do list for quite a while. But there was a general feeling that there was an agenda for change. Many local authorities had ideas of how things were going to change or planned to change in the future. And then finally, just a summary of the findings. So most commissioners interacted with many partners each week. Interaction with providers was the highest in terms of external partners, and most areas had provider forums. Areas specify precise requirements with providers within contracts, and staff conditions were less specified, but early findings comparing the 2007 data with the 2017 data indicates that these had increased. In terms of collaboration, providers were consulted in the development of service specifications more so than health partners or service users. And then finally, monitoring data. Data from both users, carers and providers was used in most areas. And again, the 2007 data indicated that the use of that type of performance data had increased across local authorities. So now I'll pass you to Karen.
Gosh, well, I don't know what kind of impression you get from all of that data in terms of what the commissioning between commissioners from local authorities and home care providers, what that process is like. And I don't know whether you come away with a sense of it's working well, or whether you come away with a sense of it being quite challenging. What we wanted to do with our qualitative data was to look at what was behind some of the comments that commissioners were making on their survey, and then also try and find out what it was like from a provider's perspective. Being very aware that providers, as we saw there, could be a small company, and they are all business, or certainly the ones we talked to were all businesses, for-profit businesses. They could be small, they could be large, and actually our understanding from their perspective was really quite limited. So our intention was to look at we looked at a whole range of things. This morning I just want to talk about two things from our matrix. One is the question of control and the issue of contracting, and the other that I would like us to look at today would be the question of collaboration. Two very different approaches that seem to have potentially could be complementary. They could be two things of the relationship between commissioners and providers that were actually quite at odds, and we wanted to find out what it was like. So we'll start just looking at the commissioner's perspective. This involved interviewing 10 commissioners from local authorities who were contracting with private or independent providers. I think we can probably safely say commissioning in progress, it's complex and potentially very dangerous. So here's a quote. So a commissioner said to us, working with fixed procurement rules and regulations can sometimes be counterproductive. That's what they're being asked to do, to work within fixed rules. They're saying it's counterproductive. What did they mean by that? Well, when we look at what they actually said, and I'm sorry, it's actually quite small, it's an incredibly complex process with huge amounts of variation, and I think the survey certainly showed that as well. The language they used was could be quite different, could be quite personalised. It could be the Rutland framework for commissioning, or it could be, so the language was all quite varied, and it made it very difficult for us to see any comparison between the different local authorities. It could be a spot contract, or we could have a little bit of spot, or we could have a little bit of block. And it went on like that in our interviews, that there was a lot of variation in how they set up the contracting with providers. The processes for tendering were certainly very long, and the processes for actually assigning individual cases could be quite clunky, quite awkward. And there was a tendency to collect mountains of monitoring data without a specific purpose. And this is all what we were told by the commissioners. They were saying, you know, we collect all this data and we never look at it. So complex and complicated, lots of changes, changes in the strategic direction or the organisation of the local authority, changes in leadership, and changes that had to come about because of operational necessity. Things were going wrong, and we saw that very clearly in the slide in terms of dissatisfaction with the supplier providers. So it's a very difficult territory that commissioners are working in. The majority of contract arrangements didn't provide a guarantee of work for providers, and obviously that led to great instability. And I think this is really important, the question of contracting and how tightly do we write our contracts? How tightly are they specified? If we look back at the survey results, there was a lot of specification about the things that providers were expected to do. Actually, less specification about paying for mileage, paying for sick pay, and paying for some of the things that were really important to providers. So how tightly is the contract specified seemed to be quite important, and what we felt was that this was quite a constraining part of the process for commissioners. So what did commissioners do about contracting? We need to be well specified, we need to monitor what we're doing, was what they were telling us, but actually they were constantly looking for ways to adapt the system. And they were very, I need to find the right word for it, because actually they were very wily about what they did, and they almost relished the challenge, or some of them did, to adapt the system to make it work more successfully for their end user. And that was in their mind for some of them. So we had comments like, I don't think there's a blueprint. And we certainly got that impression from talking to across a number of commissioners. And then another one who says, we're developing a very non-prescriptive contract. It talks about outcomes for people. So that's really interesting because we moved from being a mindset that says we need contracts that are really tightly prescribed through to this, actually, that wasn't delivering outcomes, and that's what we're trying to achieve. So what was their relationship like working with providers? You know, potentially, if you're purchasing something, the relationship should be very simple. But let's just look at the changes that some of the commissioners were talking about. I think this is a really, really powerful quote. A few years ago, it was all adversarial. It was confrontational. But now we're listening. And we're trying to work through the issues together. And I think that's a quote that really captures this sense of it's not just a contractual relationship, it's a collaborative relationship, or that's what some commissioners are trying to move towards. So we then talked to our providers, or some providers. We talked to 20 providers, which was a great experience in finding out what it was like for them being on the receiving end of commissioning. And I'm sure there won't be any surprises for you that their response was, wow, it's a very complex process. And that there were tensions between the contracting process and collaborative initiatives. There was a willingness on the part of providers saying, we'd like to be working towards outcomes, we'd like to be doing things differently, we'd like to be working flexibly, but we can't do it within a really restrictive contract. And this is the Commissioner's view, about working with providers. The relationship building was described as a tightrope. So they were balancing a commissioner was balancing different stakeholder perspectives. And one of them they mentioned was, if we get it right with our providers, then our social workers are complaining and saying that we're not giving them a hard enough time. But actually, we've had to learn, because if we give our providers a hard time, we lose them. So regular forums with providers existed, but it was actually attitudes that seemed to be much more important than the format or frequency. So what we definitely got a picture that there was a continuum of working practice with care providers. So the nature of the relationship seemed to be that it could be one that was quite distant, very contractual, very transactional, this is what I want you to provide for me, through to ones that were much more collaborative. And as you'll see, when we talk to some of the providers, there are some instances where they actually sit alongside. Providers, commissioners and social workers sit together and they're saying, phew, we don't have to spend time phoning people up to kind of make amendments to contracts and so forth. So we certainly felt that there was a sense in which some commissioners were moving in this central ground. They were beginning to explore joint initiatives, which was more about talking together about how we could improve services than how we could improve the specs that we were creating. So I'm just going to whiz through these because I won't stop on those. So we can talk about what were the views of the providers and their views of commissioning arrangements. And I'm going to look at this from the point of view of contracts, the question of what it was like contracting, but also this whole sense that they're operating in a market. This is what's been required of them, and this is where we are. It's been an expectation for many years that we're operating in a market, and there is a big question mark about what kind of market we're operating in. So it's hugely complex for providers, hugely time-consuming, tendering and operating a contract. Time that we got the impression probably wasn't really factored into the funding. So it's a cost for the provider agency. They felt there was a lack of strategic planning at the commissioner level or local authority level, that maybe just they weren't included in any of that. They weren't part of that discussion. Competition is fascinating because the whole point of a market is that there's competition out there. In fact, competition wasn't a big issue for them because they were, as they said, we've got plenty of clients. So we're not competing for the clients. Where the competition existed actually was we're competing for good care workers, because our care workers will either hop to a better option in another care provider, or more likely to a completely different sector, because it's easier and you're not dealing with a lot of the challenges that they felt their care workers had to deal with. So their perspective of their relationship with commissioning arrangements was that many of them did describe a very distant contractual relationship that was quite problematic. There was a great sense in which some of them were beginning to develop this trusting relationship on point number 3 there. And I'll let the quotes speak for themselves. So we've got one here who says, it's as if they don't care. They don't even pay us in time. Our invoices don't get paid. There has to be more of an inclusive relationship, and this is moving towards working together. And then we have the one service where they're actually sitting together, everyone in one hub. Okay, let's just summarise. A real sense that there was a contradiction between the contracting and tight specifications and the collaboration. And I think our challenge really was, let's just move on from that in terms of the summary. There were evidence that processes were supporting partnerships were in place. That's what Sue's survey, or the survey that was done within our team, said that. But it didn't reflect the complexity of the relationships between commissioners and providers. And the partnership ranged from something very transactional through to something more collaborative. Collaboration, I think, was described as the mechanism for commissioning for outcomes. In summary then, the market model in home care has created a tension between setting tight contracts and innovative ways of operating, but the collaborative approach where people seem to be moving to seems to be the direction that would bring opportunities for commissioning for outcomes. We should have said this is a whole team approach, and there were many of us part of this this piece of research, and obviously we want to say thank you to NIHR for the funding of it. Okay.
I think if we move straight on to our final presentation and then have questions on all 3. So can I welcome Elsa Cameron from University of Bristol, and I'll let you do the rest.
What about my talk? Where's it gone? Which one do I press? Shift?
One of the people whose success...
Great. Okay, so my name's Elsa Cameron. I'm from Bristol University, and I'm here with some of the research team, Ellie Johnson and Randall Smith, who hasn't quite got here yet, but he's on... Oh, no, he is. He's here. So I'm going to present some findings from a study we completed a week ago. So let's have a look. Wrong button. Okay, so the idea of the study came from an observation that each member of the research team had made, which was that the settings, the social care settings for older people that we'd been working in, were starting to rely on volunteers to provide services, additional services. So the work we'd done recently in extra care settings suggested that as funding for housing support had been removed, people were beginning to rely on volunteers to bolster social care provision. So the study came from the perspective that we wanted to start to develop an evidence base for the use of volunteers in social care. We wanted to find out what motivates managers to involve volunteers, what motivates volunteers to become involved, what the perspectives of paid care workers and older people were about the involvement of volunteers. So in essence, the project was very much about learning lessons, and the research took place in 7 settings in the southwest, and we visited each of those settings and we talked to managers, coordinators, volunteers, paid staff and older people receiving services. And this slide just attempts to give you some sense of the type of settings that we went to, which were all very different. So setting 1 was a befriending programme which was run in a retirement village that had a very long tradition of working with volunteers. Site 2 was a day centre where volunteers helped out with activities. They might run the bingo session, they might take part in quizzes, they might run craft sessions. Day 3 was a day setting for minority older people, and the focus of this was very much on social isolation, developing friendship. Site 4 was a volunteer agency that ran physical and musical programmes in residential care settings. Site 5 was a care home where volunteers assisted with activities. Again, they ran bingo sessions, reading groups, and some provided spiritual visits to residents. Site 6 was a hospital discharge service that was run by a national charity, and here the volunteers would visit older people in their homes who'd recently been discharged and would support them to regain their independence. And Site 7 was a time bank, and here the volunteers worked to provide a lunch club for people living in the local community. And it was very much the local community had identified that older people appeared to be isolated, and they wanted to respond to that. So many of the older people that we spoke to really welcomed the involvement of volunteers, and they gave glowing accounts of their interaction with them. And in some cases, particularly the befriending service at the retirement village and the activities programme, the older people there spoke of developing close friendships with individual volunteers. And they said that they actually looked forward to seeing these people every week. So, for example, this older person who took part in an activities session said of the volunteer, "She fills our day. She gives you something to look forward to. These people that do these jobs, they're a certain character. She's just one of them. So we look forward to Wednesday. We try not to miss them if we can help it." So older people who were living in care settings also talked about the importance of the outside perspective coming into their care settings. So there were different perspectives on the role of volunteers. So on the one hand, many of the coordinators that we spoke to and paid care workers agreed that volunteers brought an added value to their services. So a care worker at Site 5, the care home, expressed this when she said, "It gives our residents a better quality of life. It gives them more opportunities. It enables them to have more one-to-one time with somebody and to form more personal relationships with somebody, whereas we're here and we're just rushed at times." Now, on the other hand, managers particularly placed a great deal of emphasis on what was needed if the potential of volunteer involvement is to be realised, particularly when supporting one-to-one, particularly vulnerable older adults. So a manager at the day centre for a minority group recognised this when she said, "With volunteering one-to-one, you need to have a proper job description, a volunteer organiser who can look at their training, do all the checks with them, do everything. No matter what training I offer the volunteers in the day centre, I still not be comfortable in sending them to work one-to-one." And what we observed across the 7 sites, and it is a small study, was that the nature of the volunteer involvement was quite different. And there appeared to be these 3 models. So the first one, augmenting existing services. So the volunteer role primarily augmented what was already happening. It was in addition to what already existed. And this included the retirement village befriending service and the activities and musical exercise in care settings. On the other hand, volunteers at some settings were used to fill gaps, particularly in instances of short staffing. And this appeared to happen most in the 2 day centres that we visited and one of the care settings. In other cases, volunteers provided completely discrete, freestanding services. They rarely came into contact with any other paid workers. And the examples of those are the Home from Hospital service and the lunch club provided by the Time Bank. So taking that a little bit further, where volunteers augmented or provided a discrete service, their roles often had very clear boundaries separating what they did from what paid members of staff did. And this was particularly clear at Site 1, the retirement village, where one of the care workers said, "A volunteer is more of a companion when we're the ones who do personal care. We do intimate things. We do the medication. I would never expect a volunteer to do that. I would say they enhance people's lives more, especially if they haven't got any relatives or friends that visit them very often." So in contrast, where volunteers were used to fill gaps in provision, it was much less clear what distinguished their role from that of paid members of staff. So a volunteer at one of the day centres said, "It's not official, but sometimes I think we're treated like cover if a member of staff happen to be out, like because of holiday or sick leave or things like that. But if everyone's in, we're usually just extra helping hands." So some organisations had a site-specific volunteer coordinator role. Some had a regional one and some had no coordinating role at all. So at sites where there was no coordinator, recruitment and managing volunteers was most often done by someone who was already managing paid members of staff. At sites where there was a volunteer coordinator, their roles varied, but most were responsible for the day-to-day management of the volunteers, and some were responsible for their recruitment, their training, and providing support. And this was important to volunteers because they described the presence of a coordinator as something that actually had swayed their decision to volunteer at those settings. And this quote kind of captures that. So this comes from a volunteer, and it was actually the fact that a coordinator existed had been the key influence for volunteering at that organisation, because the role suggested there was a structure, there was a process, there was support. She said, "I think if you're dealing with someone who's trying to pick that up, amongst other things, the worry is that you won't feel like you're needed as a volunteer. And I knew when I phoned here, someone called me back and they had time to talk me through the whole process, invite me to come in, sit down and talk to them. It felt professional because there were forms to fill in. They did the proper checks." So for several years, there's been an assumption, largely on the part of government ministers, that there's an army of volunteers willing and waiting for the opportunity. So, for example, as Norman Lamb said in 2014, there is a great army of people out there. If you can somehow tap the energy and commitment that they're prepared to give, you may start to find some of the solutions to the challenges that we face. However, our research suggests that that just isn't the case. So even at settings where they had a long history of working with volunteers, they told us that they were now really struggling to recruit people. And a range of reasons were given for that, and those included increased intergenerational care, so grandparents caring for grandchildren or adults caring for parents, rising female employment rates, particularly amongst younger women, changes to pension legislation, which meant people were delaying retiring. And finally, in rural areas, we were told that there were additional difficulties recruiting volunteers because of access. So the first quote here illustrate some of those problems. The volunteer coordinator at Site 1 said, "We just find that those retired, well, most women are working in some capacity now, or they're having to stop their volunteering because grandchildren come along and they have to take on caring responsibilities." So the implication is women have many pressing demands on their time. The difficulty of recruiting volunteers to the hospital discharge service, which was based in a semi-rural area, had led the organisation to make the decision to actually pay someone to become a paid support worker. And they would focus on the most challenging cases. And this was particularly ironic because this national voluntary group ran all of their services nationally through volunteers. So this was a new departure. They couldn't recruit volunteers, so they had started to recruit paid members of staff. A key theme that emerged in the study was the importance of supporting and valuing volunteers. Now, as I've said, the data suggests that this is easier to do when there's a volunteer coordinator. And significantly, most of the volunteers we spoke to told us that they felt appreciated by the organisations where they were volunteering. They also felt that paid members of staff valued them and that the older people they worked with valued them. And when we asked them why they felt like this, they told us about the small tokens, the fact that paid members of staff said hello to them, the fact that they were invited to a Christmas party or a summer barbecue, the annual volunteers recognition event that was held. All of these things were really important to keep volunteers motivated and engaged. And this quote demonstrates the importance of volunteers feeling appreciated. This volunteer ran an exercise program in a care home. And although she didn't feel particularly valued by the manager of the care home, in fact, the manager had never once spoken to her, she felt appreciated by paid care workers who had actually bought her a gift at Christmas. And she said she didn't expect people to say thank you, but when they did, it just made a lot of difference to her. She said just someone to say thank you is usually enough. Just a little bit of appreciation doesn't hurt anybody, really. And that sentiment was echoed across all of the volunteers that we spoke to. So the literature also talks a lot about volunteers being motivated to get training through volunteering. And actually, that wasn't the case in our study. So 3 of the sites provided no training to volunteers at all. At the remaining 4 sites, they provided training, and that might include introductions to vulnerable adults policies, use of wheelchair, working with people with dementia, health and safety. But when we talked to the volunteers themselves, very, very few of them actually said that training was one of the motivations for volunteering. And actually, the picture was the opposite. Several volunteer coordinators and managers told us that additional compulsory training was perceived as a burden and sometimes led to volunteers ending their involvement with the programme. We were also told that if volunteers had to wait a long time to complete initial training, then they were likely to find an alternative opportunity elsewhere. So there was a real sense of the need to capture the enthusiasm of new volunteers and complete initial training in a timely fashion. And as I've suggested, there was a real problem with organisations requiring additional compulsory training. And this manager told us, at various points in the last few years, we've lost volunteers en masse because of insistence on compulsory training, and we've lost good volunteers. They just had enough and went, because the thing is, we'll pay them to come here to the training, but we're not paying them for their time. And this charity had recently arranged training, compulsory training on safeguarding for all their volunteers across England. And it didn't go well. In fact, several volunteers told us that they didn't have time to attend the training, particularly because it was at a distance from their own homes. Other people said the training wasn't useful, and we were told by managers that quite a few volunteers found it patronising and also caused them a great deal of anxiety. So our research, we hope, demonstrates that volunteering can bring benefits to older people, to volunteers themselves, and to the organisations where they volunteer. But as we've seen, there are challenges associated with the involvement of volunteers. And in addition to those challenges, we've identified what we've called the volunteer paradox. And what we're trying to capture with this phrase is the sense that at the very time when social care organisations are under increasing pressure, due to a lack of funding, that means they need to involve volunteers in order to keep the show on the road, the actual experience of volunteering can be more tricky because of the wider stresses and strains that social care agencies are working under. And here's the quote. And this comes from an area manager who said, "I think the cuts in social care have a direct effect on services that's either putting a load of pressure or just closing down services. And then when you get a service that's under stress and under pressure, it's not a good place to volunteer. It's not a good place for a volunteer to be if everybody's rushing around, you know, trying to provide care on an impossible amount of money. There's a knock-on effect on how you then get volunteers, how you care for volunteers. I think the casualty of the cutbacks definitely is impacting on volunteers. And this big thing about if we could replace people with volunteers, I think that's an insane idea. It's irresponsible." And that was a view that we heard quite often. So, on our research evidence, we hope demonstrates that volunteers make an important contribution. But what we want to emphasise is that volunteers are not a free resource. And on that basis, we've got a few ideas for the sector. So the first idea is the need to educate commissioners about the costs and the challenges associated with working with volunteers. Specifically, our research suggests the importance of having a volunteer coordinator. And in our view, that role needs to be funded. A coordinator role is an essential element of supporting volunteers, and it therefore contributes significantly to enhancing the quality of the volunteer contribution and, in essence, the experience of receiving social care services. So, for example, coordinators were usually the route through which volunteers are recruited. They were involved in organising and carrying out the training. And most importantly, they were the ones offering support to volunteers because they knew the challenges of working in that sector and that setting. Now, all of these elements are really important in terms of ensuring the quality of the volunteer contribution and the quality of social care. And of course, it should be the quality of services that is at the forefront of decisions made by commissioners. Secondly, if commissioners are to be convinced of the need to fund the coordinator role, then it is important to evidence the impact of the contribution that volunteers make to the care received by older people. Commissioning decisions need to be evidence-based. So in relation to providers of services, our research suggests the need for clarity about the aims of involving volunteers. What is the service hoping to do? Are they hoping to augment existing services, or are they providing a discrete service, or are they filling gaps? Clarity about the boundaries of what volunteers do and what paid members of staff do. What can a volunteer do and what can't they do? There also needs to be support available to volunteers so that they know they have someone to turn to if they have a question about their work or about an older person that they are supporting. Now, we all know that volunteers contributing to social care need to have some basic training. However, this needs to be reflective of and proportional to the work that they're doing. It also needs to be timely and accessible. So although volunteers need training about the protection of vulnerable adults, they might only need to know enough to be able to recognise the signs and to know what to do. Finally, if the benefits of the volunteer contribution to the older people and to organisations are to be realised, then their contribution needs to be valued, documented and recognised by all concerned. Thank you.
That's brilliant. We've run excellently to time, and so we've got 15 minutes for questions before lunch. We've got the light on the panel. I'm, as a civil servant, less than comfortable in the spotlight. So I'm looking for questions, Michael. Yes, okay. I'll let you.
Hello, thanks very much. It was a really interesting trio of presentations. Something that struck me, and I think it emerged most significantly probably in what you were saying, Karen, was about the commissioners, and it was part of the qualitative work, and one of them saying that they were interested in looking at outcomes. And I thought, if they're not looking at outcomes, the commissioners, what are they looking for in a contract? I mean, it's central, I would have thought.
And that probably is absolutely what we felt we were picking up, was this focus on process, because it's doable maybe, and that the focus on outcomes, it did genuinely feel like it was on their wish list, and we're going to be working towards it, and that's what they all said when they returned their survey. But when we talked with them face to face, it was much more. We had some who definitely tried it and got their fingers burnt, and others who were saying, had lots of the language saying, we're going to move towards outcome-based commissioning, all co-production and all the rest. But we're still talking in terms of, but we have to have our KPIs, we have to have very tight contracts, we have to monitor very tightly. So it was almost like they hadn't quite come to a realisation that those two things are very difficult to work together.
Yeah.
Hi. Hi, I'm Sam Rickman. I work for the PSSRU now, but only for a couple of weeks I have, and prior to that I worked for local authorities, so I guess this is more with a sort of local authority hat on, but it was, the same presentation. I was just wondering really, I got the overarching theme that came through very clearly about the sort of, what you just said, the tension between really the purchase provider split and and commissioning for outcomes, but on a sort of, from a local authority perspective rather than from a sort of national perspective, I wondered if you, because some of the stuff you had in there was really interesting, like the big pie chart of how many providers different local authorities had. And I guess I wondered if you had any recommendations about best practice for that sort of thing for local authorities, because I think it's quite different. It's difficult, sitting in a local authority, you don't, obviously I think there's quite high risks of only having one provider, but the more providers you have, the more risk that any one of them might fail. So what's the right number? Is it 3? Is it 6? Like, that even, those are quite difficult questions to answer.
But we did ask how many providers do you have, and the range I think was from 1 to, there were hundreds, 500 plus. So it is really varied, and I think it is whatever suits the particular of your local authority. And there's also spreading the risk, because provider failure is obviously an issue. But we've looked at the setting up the relationship, and if you've got hundreds of providers, how do you manage that personal relationship that is essential in commissioning home care?
Great. Another question. Yeah.
Thank you. Richard Banks, just to pursue that a little, and it's about workforce. Home care is only about workforce, really. And actually, whether you've got 6 or only one provider, they're all working using the same people. And local authorities have a responsibility for workforce strategy to make sure there's enough people in the area to deliver the services. Did any of the commissioners that you talked to talk about their responsibility in that direction? rather than the things that you talked about. Because, of course, what we know is that most of the home care organisations that have failed because they didn't have any staff to deliver the service, particularly in a rural area.
Yes, they certainly did talk about it, and interestingly, which is perhaps a good thing, both providers, the care providers and commissioners talked about actually the lack of status for care workers was a big issue, and that recognised that that wasn't being addressed in any way, and that I think the local authorities commissioners felt a little bit constrained because in the end they're reliant on how the care providers do their recruitment and support staff and so forth, whilst the care providers are totally reliant on what the commissioners spend. So it's a kind of very, very tense relationship. And it was one that I almost felt they couldn't quite control. So when Sue talks about some having very many providers, we talked to one commissioner who said, well, we changed our contracting arrangements, we put this framework in place, and we went from 6 providers to 250, and it was a nightmare. And it was almost like he or they weren't able to quite predict that, and it felt like a very difficult arena to be saying, if I do this, then I know this will happen.
Right, we've got a question at the back of the room, Michael. I'll send you back.
I suppose I was just going back to the kind of fundamental motivation for commissioning. So when we introduced competition in healthcare with fixed tariffs, the idea was that providers would compete on quality. I mean, from what you've said in your presentation, there really isn't much competition in the market, and actually they're competing with each other for staff. Yeah. I mean, I suppose another idea of having lots of different providers is that those providers might be better placed to meet and identify local needs. But then the other thing that came out of your presentation was that they're predominantly for-profit organisations rather than kind of grassroots community groups. So, I mean, it might seem a naive question, but I mean, is the motivation for commissioning in this case simply that the local authorities don't have capacity themselves to bring these services back in-house? Or what is the kind of political or philosophical motivation for commissioning in the first place?
Let's just get ontological.
These are huge questions, and I think that we were able to, well, the impression I got was it's a very imperfect system, and the commissioners are working with a really imperfect system, which is the market model, but that doesn't suit really care. On the slide I skipped over was one where a commissioner said, if we just think about this as transactional, we forget about the person who we're caring for. And there was a real sense that they didn't want it to be transactional, but in fact a market model encouraged them, or perhaps it was easier to operate as a market model that didn't think about the outcomes at the end and so forth. And they didn't want that. And just to say, I didn't touch on this at all, but we tend to think about the for-profit organisations as just being businesses. They talked about themselves as businesses, but in actual fact, a lot of them had a real solid sense of what their local community was all about. They recruited from their local community, and they were they were very value driven, and I was quite overwhelmed by that unexpectedly, that they weren't just, I need to make a lot of money, or I need to be in a contract that gets me by and makes a profit. They were actually much more value driven.
Can I just ask, I'll use chair's privilege, you asked Karen Jones, did any of this come through the national work, which you were talking about, the provider picture?
Not for this
on delayed
studies.
transfers, on
I don't think so, but it mirrors previous research PSI used done about providers.
Yeah. Okay. More questions. Shall we have some on volunteers? Well, we've done a lot on contracting, haven't we?
So I'd like to talk about volunteers because I am one, and I'm a trustee with a charity that employs volunteers. And I think your slide set pretty much said that the paradox is, had you heard cats? So volunteers are not line managed. They don't have line management support or HR support. They're often lone workers. And I understand completely, because I experience this every day, why people stop volunteering for one organisation and find themselves a valued role in another organisation. My question is really, it's about that paradox. It's about, did your findings or conclusions, because you did skip some slides. Was it you who skipped some slides? No, okay. Then in that case, what I was missing from the information that you presented was how can volunteering be co-created, co-designed, co-produced and co-delivered in the settings where volunteers work, so that volunteers have a stake in a charter for how their time, effort and commitment is deployed.
Very good question. So I think there are opportunities at some of the settings that we went where there was a long history of volunteer contribution and a sense of the local community and discussion with older people about what they wanted from volunteers. I think there is opportunities to co-create. But going back to the point about commissioners are involved in this, and no, and I think that is a problem. There's an educational campaign that we need to kind of pursue, but there is some co-creation. And then in other settings it was quite clear, well, I don't know, it was quite clear. My sense was that there was a little bit of firefighting going on, so you know, co-production was a long way from where they were at that moment.
Great, thanks. That arises from a few of the presentations we've heard.
Hi, my name's Alicia. I'm from the Marie Curie Research Centre. Had lots of different jobs in different places and worked with lots of volunteers. But the thing that, sorry, I've forgotten your name, the lady that did the URVIC project.
Ailsa.
Hello, Ailsa. The thing that struck me from your presentation was, there's a lot of information out there about best practice in terms of volunteering and the role of coordinators and how to support volunteers, and much of it echoes exactly what you've said. But one of the things that it does usually say is a volunteer should never fill the place of a paid member of staff. They should enhance service, not deliver core services that paid people should be doing. And what struck me from your presentation is you were talking about volunteers filling gaps for paid staff where there were absences. And I thought for me that was a particular area of interest and perhaps a potential future area of study, whether it would be useful to get a perspective on the prevalence of that and the role of commissioners in instigating that in some way or another. So I just wonder what your thoughts are on that.
Absolutely. I think that's a really interesting area of future study, to actually look at how many organisations are moving towards that reliance on volunteers to cover for paid members of staff. But there was some, yes, that's at one end of the extreme. At the other end, there was the kind of well-organised programme, and they were listening, they were using the evidence that was out there. But yes, it's in those settings where life is very busy and they're firefighting that they're not thinking about the evidence and the best practice. And so I agree, there is a research project to be done there. Yeah.
Brilliant. That's what we like to hear. We've got time for a couple more, I think. I don't know, delayed transfers, you had to go after the session, but yeah.
Hi, Francis Dickinson. I'm a freelance researcher these days. There's a question for Karen Jones. Karen and I had the pleasure of being around the same table back in 2016 when we were looking at delayed transfers of care. And my question, Karen, is it looks like it's a good thing in terms of vanguards, particularly the urgent emergency care, having a positive impact on delayed transfers of care. But as we know, causation is sometimes very difficult to establish. There can be an association without causation. And I wondered if you had a control group or anything like that for non-vanguard areas and what was happening to DTOC in those areas to kind of help establish that causation.
Great. That's...
Intari, did you want to... Intari, did you want to answer that?
Well, I can answer that on our behalf. So Steve Allen from the research team. So part of the work, indeed, the main problem is causation, and we're unable to kind of fully establish, as Karen said in her presentation, if it is urgent and emergency care vanguards that are delivering that reduction in DTOC. Some of the analysis that we've done to try and check that out is to compare the data before the vanguard sites in our analysis were vanguard sites, looking at their historical data. And so we've looked across time to see whether they were performing better or worse compared to other local authorities. And so we've found that they were actually performing worse before time. That's right, isn't it? And so it's something that we're still trying to establish. But either way, what we think is that if it's not the vanguards that are causing the reduction in DTOC, something has gone on within that model that's going on. And so what is it that's causing the reduction in DTOC? Because it has happened in those sites significantly more, whether it's a causation that's developed from that completely.
That coincided with the vanguards, and so I think we can finish on a tricky methodological answer, unless there's one more final urgent question, because we're running into lunch now. Okay, well, can I just ask everybody to thank the panel again?